Hi, I'm Scott Schiffman, and I will continue our discussion on femoral acetabular impingement. So the objectives of my presentation is to first review the pathomechanics of FAI and acetabular dysplasia. Next, we'll turn our attention to the common labral and cartilage injury patterns which can occur, as well as normal variants. Then we will touch on the imaging technique, including radiographic views, CT, with 3D reconstructions and MRI arthrography. Then we'll turn our attention to external impingement syndromes, which might confuse the surgeon into thinking that the patient has femoral acetabular impingement. And throughout the talk, we'll focus on concepts of how the surgeon is thinking in terms of surgical management. So what is the motivation behind studying femoral acetabular impingement? The idea is what's referred to as a hip preservation, meaning that we would like to prevent patients from developing osteoarthritis. So I'm going to use this patient as a case example to illustrate these concepts. This patient presented to us as a 20-year-old, and you can see that as a 20-year-old, the patient has a cam deformity at the femoral head-neck junction, as well as an os acetabulum, or what's referred to as a chronic acetabular rim fracture, which is suggesting sequelae of chronic trauma of the acetabulum from this cam deformity colliding with the acetabulum. This patient goes unchecked for a period of 9 years and presents back as a 29-year-old. And at this point in life, the patient looks as if they've developed a moderate to severe osteoarthritis of bilateral hips. So a surgeon would argue that if this patient was managed when they were either 15 to 20 years old, back when all they had was the cam deformity and the os acetabulum, if they were capable of trimming off this accessory cam deformity, resect the os acetabulum, do a labral repair and cartilage repair, that this patient would be able to avoid needing a hip replacement within the next 5 years as a 35-year-old, and possibly they would be able to go until they were 60 years old before they would need a hip replacement. So that's some of the motivation behind studying femoral acetabular impingement. Now, to give real-world analogies to the idea of impingement, I think that this is more easy to understand in real-world situations. Giving the idea of a door that's constantly getting stuck, because this side of the door is more prominent. So this would be my cam analogy. And then if you're a surgeon and you have a door that keeps getting stuck, you take a device called a planing device, and you plane off this portion of the door, removing portions of the wood, until the door is freely able to open and close very smoothly. And then you've relieved the cam deformity. Here in Rochester, New York, we get a lot of snow. And here's an example from my old car. You can see that I have a lot of snow and ice buildup on my car, involving kind of the anterior acetabulum of my car right here. And the snow and ice buildup is producing kind of an analogy to the Pincer deformity, in which my tire is not able to rotate very freely. And after some careful kicking of the snow to relieve this obstruction, now my tire is able to more freely rotate. So this is my analogy to the Pincer deformity. Now, in the human body, the idea of impingement is a little bit more difficult to conceptualize. First, I would like to talk about the cam deformity. What the cam deformity gets its name after is a car component referred to as the camshaft. So within your car's engine, you have a component which is aspherical, and as it's rotating, the aspherical component of the device is going to push on the pistons, and this will help drive your car. Now, while this is a good motion for a car to have, it's not very useful in the human body. So the analogy is the cam deformity is this bony bump, which is going to be occurring at your femoral head-neck junction. And the problem with this bony bump is that when patients go into the extremes of either flexion or abduction, this bony bump is on a collision course with this rim of the acetabulum. Now, it's not necessarily the bony impingement, which is the problem. However, there are the innocent bystanders, including your articular cartilage and your acetabular labrum, which are going to constantly experience a shearing force from this collision of the cam deformity and the acetabular rim. And this constant shearing force will eventually produce a crack at the chondrolabral junction. And this crack at the chondrolabral junction will eventually propagate into the substance of the labrum, as well as propagate along the bone cartilage interface, producing cartilage damage, oftentimes from an outside-in type of approach. So how do we assess a cam deformity on radiographs? First off, try to imagine what a normal hip looks like. And a normal hip usually has this S-shaped contour at the femoral head neck junction. And any excess bone that violates this normal S-shaped contour is what's referred to as offset. So this yellow measurement right here is measuring what's referred to as femoral head neck offset. Another way to assess the cam deformity, to assess the size of the bump, is to perform what's called an alpha angle. The alpha angle is basically a measurement. If you fit a circle, a best fit circle to the femoral head, if you have a line that runs down the center of the femoral neck to the center of the circle, and then if your other line will tell you wherever you think the femoral head is losing its sphericity, or wherever you think that this bony bump is beginning. And this is what's referred to as the alpha angle. Now, if this alpha angle gets greater than 55 degrees, this is telling you that this cam bump has been sufficiently large enough where you can predict that it might be on a collision course with the acetabulum, leading to those labral and cartilaginous pathologies that we just discussed. So this is the importance of the alpha angle. Here's what the results of a cam type femoral acetabular impingement looks like on MRI. Here we can see the classic labral tear pattern at the anterosuperior contralabral junction right here, extending all the way through the base of the labrum, resulting in this paralabral cyst. And then we could also see that the tear propagates into the substance of the labrum right here. And we could see the areas of associated cartilage loss along the anterosuperior acetabulum, better seen even on this coronal projection with a full thickness cartilage loss, as well as a subchondral cysts. So now we get into the concept of acetabular coverage of the femoral head. The way that we measure coverage of the femoral head by the acetabulum is with an angle measurement called the lateral center edge angle. And what your lateral center edge angle is basically if you best fit a circle to your femoral head, if you drop a vertical line to the center of the circle, and then the other line is wherever you think your acetabulum is ending. This will give you an idea of how much coverage you have of the femoral head by the acetabulum. Now this lateral center edge angle, the normal values for this is between 20 and 40 degrees. If you have a case where you have more than 40 degrees of coverage, then you're over covered. And this is what's referred to as a pincer impingement. And if you have an angle measurement that's less than 20 degrees, then you're under covered. And this is what's referred to as acetabular dysplasia. So ideally your coverage is somewhere in the middle, between 20 and 40 degrees of acetabular coverage. So that brings us to pincer impingement. Pincer impingement gets its name from this pincer device. This is a tool, and this also looks like a lobster claw or a crab claw, and it kind of forms this like pincer grip type of deformity. And the idea behind this is that this rim of the acetabulum takes on this, because it's over covering the femoral head, it kind of takes on the shape of like a pincer claw. And the same problems emerge as with cam type impingement, where if the patient goes into the extremes of either flexion, abduction, it basically puts the femoral head neck junction on a collision course with the acetabulum. And again, you have the same innocent bystanders, including the articular cartilage in the labrum, which are constantly going to get repetitively damaged by this collision. But then the question becomes, how do patients develop this pincer type of impingement? And usually the result is of having abnormal acetabular morphology, and usually it's by having too deep of a hip socket. So how do you recognize that a patient has too deep of a hip socket? One way to do it is to assess where the medial wall of the acetabulum is. Here we can see that the medial wall of the acetabulum, and we're looking at its relationship to the ilioischial line. The ilioischial line is the sclerotic line right here. So I'm going to add on some graphics. We can see the orange line right here is the medial wall of the acetabulum. If the medial wall of the acetabulum gets medial to your ilioischial line, this is what's referred to as a coxa profunda abnormality. And coxa profunda means you have a deep hip socket. Even deeper hip socket is what's referred to as acetabular protrusio. And with acetabular protrusio, you wind up with your femoral head getting medial to your ilioischial line. So you'll notice that in both cases where we have these a deep hip socket and an even deeper hip socket, you'll notice that the lateral center edge angle in both of these cases is markedly abnormal, and that we have over coverage of the femoral head by the acetabulum. So this concept of a pincer impingement is easier to understand. The one that's a little bit more complicated to understand is the idea of acetabular retroversion. And this is also called cephalad acetabular retroversion because the retroverted acetabulum is usually occurring more superior on the joint. And to illustrate this point, I have an axial slice from a CT scan in the cephalad position. This is when you're just starting to encounter the femoral head. And in most normal patients with a normal acetabular version, the anterior wall of the acetabulum is usually less prominent than the posterior wall of the acetabulum. And that produces the face of the acetabulum kind of pointing in a more anterior direction. Whereas in patients with acetabular retroversion, the anterior wall of the acetabulum is more prominent than the posterior wall of the acetabulum. And that produces an area where the face of the acetabulum points in a more posterior direction. The problem with this is that now you have a very large anterior wall of your acetabulum, and you can imagine that if the patient goes into the extremes of flexion, that the femoral head neck junction is going to collide with this very prominent anterior wall of the acetabulum. So how do you recognize this on plain film? The way to recognize this is what's referred to as the crossover sign. So you'll notice that in a normal patient with a normal acetabular version, the anterior wall of the acetabulum and the posterior wall of the acetabulum essentially diverge and don't intersect. And then patients with the acetabular retroversion, the anterior wall of the acetabulum and the posterior wall of the acetabulum will kind of crisscross in the middle of the femoral head, producing what's referred to as the crossover sign. And you can imagine extending this even further and thinking of this almost like as a figure of 8 type of abnormality, or even as an infinity sign. So this is crossing over of the anterior and posterior walls overlying the femoral head is telling you that you're dealing with a patient with acetabular retroversion. And then even though this patient has a normal joint space, you should be thinking that they might have pincer impingement and they could potentially have cartilage and labrum problems. So here's an MRI of a patient with pincer impingement. On the radiographs, you could see that we have a deep hip socket as evidenced by coxa profunda right here, elevated lateral center edge angle. And then on the MRI, we could see tearing at the chondrolabral junction right here and adjacent areas of articular cartilage loss. Now moving on to the types of labral tears, there's a classification system called the Seldes classification, types 1 and 2. Seldes classification type 1 tears is basically a tear at the chondrolabral junction. So you have a chondrolabral separation. Here we could see a chondrolabral junction tear at the most classic site, the anterosuperior chondrolabral junction. And then on a subsequent sagittal imaging slice, we could see that this labral tear is associated with a large paralabral cyst here. Now, a Seldes type 2 labral tear is also a tear occurring at the chondrolabral junction. However, this tear is associated with extension of the labral tear into the substance of the labrum. So this is what a Seldes type 2 labral tear is. Now, I wanted to emphasize on this slide that the orientation of these labral tears in the coronal plane, the labrum and the acetabulum is taking on this diagonal morphology such that the labral tear is oriented like this in the coronal plane. And this will emphasize the planes which are best at capturing this labral tear. So on our sagittal plane, we're catching this labral tear, probably at like a 60-degree angle, and we're going to nicely demonstrate the labral tear on the sagittal plane. But I wanted to call your attention to this plane referred to as the axial oblique view or the Swiss view. And what this is it's a plane that's paralleling your femoral neck based off of your coronal plane. And when you create this Swiss view, you'll notice that all of these that this plane is always perpendicular to how these labral tears are occurring in the coronal plane, such that they really illustrate very well on the Swiss view, where here we can see the abnormality at the chondrolabral junction with extension of the labral tear into the substance of the labrum. So I just wanted to overemphasize the idea behind the Swiss view as one of your planes of imaging because of the classic location of these labral tears. Now for acetabular dysplasia, we're dealing with undercoverage of the femoral head by the acetabulum, as evidenced by a lateral center edge angle less than 20 degrees. So you might say, well, what's the problem with that? The problem with acetabular dysplasia is that when patients are undergoing weight bearing, they're delivering a significant amount of pressure, which is being absorbed by the articular cartilage and the labrum as shock absorbers. And in normal patients where they have normal acetabular coverage, this weight from weight bearing is getting distributed over a large area of articular cartilage. In patients with acetabular dysplasia, we're talking about a smaller area of articular cartilage and labrum trying to shoulder the load of weight bearing. And this leads to excessive force on the cartilage and labrum, producing chondral and labral damage, usually in the direction from the inside out. So we wind up with a shearing force of the articular cartilage and labrum in this direction. Now, the ligamentum teres is trying to restrict the femoral head from escaping from the joint. And in essence, these patients wind up with what's referred to as hypertrophy and eventually tearing of your ligamentum teres, as the ligamentum teres is struggling to contain the femoral head within this deficient acetabulum. Now, what this looks like on MRI, here's an imaging example. We could see this patient has a hypertrophied ligamentum teres, and we could see partial thickness cartilage injury involving the supralateral acetabulum working its way from the inside out. Here's an example of a patient with more severe cartilage and labral pathology, nicely illustrating a tear at the chondrolabral junction propagating through the base of the labrum. And then you'll notice that this pattern also propagates along the interface between the bone and the articular cartilage, producing what's referred to as chondral delamination. Chondral delamination right here. And if the surgeon goes in with a scope, this is also referred to as a carpet lesion, because you can kind of imagine this as a loose carpet on the floor, whereas if the surgeon is to kind of brush this with their scope, the cartilage will form a buckling similar to a loose carpet on the rug. And then you'll notice that in this patient, the ligamentum teres is completely torn. So this is a nice example of a chondral delamination associated with acetabular dysplasia. To summarize some of the surgical techniques, I chose to demonstrate a patient that's had Legg-Calve-Perthes disease as a child, and now they're an adult. And patients who have had Legg-Calve-Perthes disease wind up with a cluster of imaging findings, including having a large femoral head. This is what's referred to as a coxa magna, a short femoral neck, which is referred to as coxa breva. It puts their greater trochanter in an unusually high position where you can imagine some external impingement between the greater trochanter and the pelvis. And also you'll notice that because of this large femoral head, the acetabulum has had trouble keeping up with the development of the femoral head. And basically they have undercoverage of the femoral head by the acetabulum. So these patients wind up with the combinations of essentially cam-type impingement, as well as acetabular dysplasia. So you imagine that they have the similar problems that we've been talking about. Here's the MRI showing Seldes type 1 chondrolabral junction separation right here. And I wanted to illustrate this case to show some of the surgical techniques. So as a surgeon, you want to kind of debride back this bony bump right here to kind of remove the cam deformity. You want to do a labral repair. You want to kind of debride some of the articular cartilage if it's damaged. And then because this patient has acetabular dysplasia, what they do is they do what's called a periacetabular osteotomy. So they make 3 osteotomy sites in the pelvis. They rotate this portion of the pelvis laterally to achieve better coverage of the femoral head by the acetabulum. And then they place in these screws and they allow all the osteotomy sites to heal, which will help improve coverage of your femoral head by the acetabulum. The other nice thing that they did for this patient, they did an osteotomy of the greater trochanter and basically moved it down to get rid of any signs of external impingement. We're going to talk about some normal and pathologic variants. First, we're going to talk about synovial herniation cysts. This is also referred to as Pitt's because this was discovered by Dr. Pitt. I thought it would be funny if Dr. Pitt actually worked out of Pittsburgh. However, he actually worked out of Arizona and Alabama, so it doesn't roll off the tongue as easily as saying Pitts from Pittsburgh. But you'll notice that these synovial herniation cysts are cysts that are occurring at the anterior lateral femoral head neck junction. Essentially what this is an invagination of synovial tissue at the femoral head neck junction. At first, 20 years ago, this was thought to be a completely normal variant, not necessarily with any explanation as to how these were caused. But as people started studying femoral acetabular impingement, they noticed that a very high percentage of patients that have FAI also have these synovial herniation cysts. And inevitably, these synovial herniation cysts occur at the anterolateral femoral head neck junction, either where you'd expect to find a cam deformity or where you'd expect a pincer deformity to collide with the femoral head neck junction. So just be familiar that while this is a normal variant, this is also having a strong association with patients with femoral acetabular impingement. Another normal variant, which is also associated with femoral acetabular impingement, is an os acetabulum, or what's later been referred to as a chronic acetabular rim fracture. The idea here is that people thought that there was an accessory ossicle that never fused to the acetabulum. However, when we started studying femoral acetabular impingement, we noticed that a high percentage of patients with FAI also have an os acetabulum or chronic acetabular rim fracture. And the idea is that from this repetitive collision with the cam deformity and the pincer deformity, we either have non-union of the accessory ossicle, or we essentially have a fracture which goes on to non-union, creating this accessory piece of bone. The issue with having this os acetabulum is your articular cartilage and your labrum is still attached to this ossicle, such that it's not really contributing to joint stability. Joint stability in this patient is deficient, and this patient has essentially a dysplastic hip because the labrum and articular cartilage is basically attached to this ossicle, which is non-united with the acetabulum. So just be familiar with the concept that os acetabulum, while it's a normal variant, might actually be a result of femoral acetabular impingement, as it's seen in a high percentage of these patients. Another interesting phenomenon, patients with cam deformities, when the cam deformity collides with the anterosuperior acetabulum, it can act as a fulcrum and drive the femoral head in a backwards direction. And this could result in either cartilage injury or bony injury to the posterosuperior acetabulum. And this is referred to as a contre-coup injury because of the cam deformity kind of anchoring on the acetabulum, driving the femoral head backwards. This patient was a baseball catcher, was never having a hip dislocation, was kind of unaware that he had this fracture. But because he had this repetitive squatting motion as a baseball catcher, his cam deformity was driving his femoral head back repeatedly, and he wound up with this chronic acetabular rim fracture of the posterior wall of the acetabulum. As was alluded to in the prior presentation, if you have a cookie cutter defect within the acetabulum, a bony circular defect in the acetabulum at the 12 o'clock position, this is what's referred to as the supraacetabular fossa. Oftentimes this is filled with cartilage, and this should not be mistaken for either a subchondral cyst. You should not be thinking that this is a full thickness cartilage defect. Be familiar with this typical location at the 12 o'clock central position as a normal variant of the supraacetabular fossa. Now for the sulci, the most typical sites of labral tearing of the hip is at the anterosuperior contralabral junction. If you start seeing abnormalities either at the posterosuperior contralabral junction or posteroinferior contralabral junction, and it's taking on this triangular morphology with very smooth borders, then your index of suspicion that you're dealing with just a normal variant or a sublabral sulcus should be raised. Essentially, if you're seeing tears involving the posterosuperior acetabulum or posteroinferior acetabulum, you want to see extension of the tear either coming from the anterosuperior superolateral acetabulum, propagating posteriorly, almost like a slap tear of the shoulder, rather than an isolated tear of your posterosuperior or posteroinferior acetabular labrum, just because the statistics are not in your favor if you're saying that. And this triangular morphology is the tip-off that you might be dealing with a normal variant rather than a true pathology. Now to briefly talk about our radiographic technique. Here's several of the sequences that we perform at our institution. And the nice thing about the radiographic technique is that each of these views has a certain benefit for assessing for femoral acetabular impingement. You'll notice that the Dunn projection is the ideal projection for looking for cam deformities and to assess the femoral head neck offset. The AP view of the pelvis or AP view of the hip is useful for assessing for acetabular coverage, as well as whether or not you have acetabular retroversion or anteversion. And then our false profile and cross-table lateral views is useful for assessing the posterior joint space, to assess anterior coverage of the femoral head, and also to even get a good sense of the head-neck junction. So you're trying to kind of synthesize a three-dimensional structure by performing as many views as possible to kind of synthesize this information on radiographs. Now, on approximately 30% of the patients that we see that eventually go on for MRI, they do get a CT scan prior to the MRI. And the surgeons like the CT scan because the CT scan gets this fine bony data that can be reconstructed in a 3D reconstruction that the surgeons are able to manipulate in all planes. So they could kind of rotate this image however they'd like. And the surgeons are able to get an idea of acetabular coverage, where the bony bumps are located. And they get a surgical roadmap of what they would like to resect based on this 3D reconstruction. Additionally, the CT gives very nice data from which you can measure your angle measurements. So here from a Swiss projection, we're able to measure our alpha angle. Again, if the alpha angle was greater than 55 degrees, we'd be concerned for a cam deformity that might create impingement. Our lateral center edge angle giving us a sense of how much coverage of the acetabulum over the femoral head. We have a measurement called the acetabular index, which gives us an idea of how much the acetabulum is sloped in the coronal plane. So this would be raised in patients with acetabular dysplasia. And then of course, acetabular version, we could get a sense of how the acetabulum is pointing, whether it's pointing more anteriorly or posteriorly, by getting this angle measurement, telling us the slope of the acetabulum based off of the axial plane. So these are some of the angle measurements that we like to perform on our CT scans. The last angle measurement that we perform is what's called the corrected femoral version. And with corrected femoral version, it kind of gives you a global assessment of the rotation of the femur. And the way this is done is we get a scan at the femoral neck. We get an idea of the rotation of the femoral neck relative to the table. And then we also get an idea of the rotation of the femoral condyles relative to the table. And you could imagine that if we place this patient's femoral condyles into a neutral position and we applied that degree of rotation to the femoral neck, we would be able to take this 10 degrees of rotation and 24 degrees of rotation and kind of sum them up to say that this patient has an anteverted femur by approximately 34 degrees. And that kind of gives the surgeon an idea whether the patient has excessive femoral anteversion or retroversion. I'd like to also point out that, we get the axial coronal and sagittal planes with our CT scan. We also get this Swiss view or the axial oblique. Here's kind of like how that plane is constructed, paralleling the femoral neck and the coronal plane. And you'll notice that an image that would occur at this location at the anterolateral femoral head neck junction would kind of be your ideal slice to assess for any cam deformities. So this would give you a nice slice to assess your alpha angle. Finally, I would just like to glance over some external impingement syndromes. First off with iliopsoas snapping hip. In iliopsoas snapping hip syndrome, you have a iliopsoas tendon, which is very, very tightly hugging the acetabular rim. And then when the patients go into certain motions with abduction or flexion, the iliopsoas tendon will kind of click against the acetabular rim as it subluxes out of place. It'll cause tendonitis of the tendon. And for the patient, it'll result in an audible clicking sensation as they go into certain motions. So here you can see that the patient has iliopsoas tendonitis following the course of the iliopsoas tendon. The other thing to realize is that this concept of iliopsoas impingement, where if you have an iliopsoas tendon that's very tightly hugging the anterior rim of the acetabulum, it can also cause a labral tearing. And the labral tearing in patients with iliopsoas impingement is occurring purely anteriorly. So at either the 3 o'clock or 9 o'clock position, depending on which hip you're looking at, rather than the true anterosuperior labral tears that we would see in patients with femoral acetabular impingement. And of course, this could be concurrent with FAI also. Greater trochanteric pain syndrome, you'll see on the majority of hip MRIs that you do. And essentially, this is basically friction that's occurring between the iliotibial band and between the greater trochanter, where the fat that's caught in between the iliotibial band and greater trochanter is becoming inflamed. And in this case, we have frank fluid at this location compatible with greater trochanteric bursitis. So the reason that I'm showing this is that because in the majority of patients that you do arthrograms on for femoral acetabular impingement, they will also have some form of greater trochanteric pain syndrome, oftentimes associated with some tendinopathy of your gluteus minimus and medius tendons. Ischiofemoral impingement is typically seen in patients that have excessive femoral anteversion, putting the lesser trochanter kind of close to your ischial tuberosity. So this interval between your lesser trochanter and ischial tuberosity, if this gets less than 15 millimeters, this is a narrowing of the ischiofemoral space. And then the muscle that's kind of caught in between is referred to as the quadratus femoris. And if you have soft tissue edema involving your quadratus femoris, this is telling you that you're dealing with ischiofemoral impingement. So the combination of edema as well as narrowing of this interval between the lesser trochanter and the ischiotuberosity. Lastly, the concept of subspine impingement. Usually these are patients that play a lot of soccer, have chronic injuries with the rectus femoris. Maybe you think that maybe they've had avulsion fractures that kind of went unnoticed and then healed. And basically subspine impingement refers to a phenomenon where your anterior inferior iliac spine is very prominent. In this case, almost looking like an elongated nose type of anterior inferior iliac spine. And the problem with this is when the patient goes into the extremes of flexion, this prominent anterior inferior iliac spine will essentially form a bony block and limit the patient's range of motion. So they won't be able to flex their hip as much as they would like because of a bony block. And you'll notice that this is not just an isolated abnormality. This patient has acetabular rim fractures, chronic acetabular rim fractures. They have a cam deformity. So this patient has both internal and external impingement from FAI as well as subspine impingement. This was a brief overview of some of the things that might confound surgery.